Good evening, everyone. My name is Jen Nolan, and I'd like to welcome you to the fourth webinar in Arthritis and Osteoporosis Victoria's 2015 Musculoskeletal Health Webinar Series. Tonight's webinar is on the subject of the management of back pain in primary care. Before introducing our presenter for this evening, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties, please refer to the chat box on your screen. You can type a message for the presenter, for the organiser at Redback Conferencing at any time. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions at the completion of his presentation, you can actually type questions to him at any time. Can I suggest you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Eastern Standard Time. I'd also be very grateful if all participants could take a moment at the end of the webinar to complete the exit survey. It will only take you 30 seconds to complete. Also, we'll be sending out information soon about our webinars in the second half of this year, so please keep an eye out for this information. Our presenter for tonight is Dr. Chris Maher. Chris is Professor of Physiotherapy at the Sydney Medical School and Director of the Musculoskeletal Division at the George Institute. Chris holds an NHMRC Senior Research Fellowship and has published over 400 research papers. He has also received approximately $17 million of research funding and supervised to completion 26 PhD students. Without further ado, I'll hand proceedings over to Chris. Thanks very much, Chris.
Thanks, Jen. Thank you very much for the opportunity to speak tonight. What I wanted to cover was really some of my research which I think has implications for clinical practice, and so what I was going to do was to run through the studies, hopefully which will give you something to take home to apply to clinical practice. So in terms of what I was going to cover tonight, I was going to go through a couple of studies related to red flags to screen for serious pathology. I was going to cover the PACE trial, which looked at the value of paracetamol for acute low back pain. We've recently published a paracetamol review in BMJ that generated huge media interest, so I thought I should sneak that in there. And because I did that, we may not have time to look at the trigger study, but I'll see what we can do. So at the moment, that's sort of the running order, and we'll see how we go. In terms of an introduction, I guess most of you understand some of these data, but I think it probably needs to be we need to set the stage here. So in terms of healthcare costs, you've got these astronomical figures for back pain. So the earlier study by Walker suggested $1 billion per year in Australia. The more recent studies report from Arthritis and Osteoporosis Victoria suggests that the cost is closer to $5 billion per year. In terms of non-healthcare costs, you've got the indirect costs that Bruce Walker estimated at $8 billion. The area that I've become more interested in recently as I've got older myself is the impact of back pain on older Australians, and something we forget about. But in terms of health reasons keeping older Australians out of the workforce, it's the #1 condition. The second one is osteoarthritis, so quite important for the group sponsoring tonight's talk. And in terms of your risk of being out of the workforce, if you're aged 45 to 64, back pain quadruples your odds of being out of the workforce, and that problem reduces Australia's GDP by about $3 billion per year. So it's a really big ticket item. It's also a very common item, and this explains why the burden is so high. So at any point in time, about a quarter of Australians would have back pain. Across the month, about half of them. Across a lifetime, most of us will have an episode of acute or recurrent low back pain. And the thing about back pain that contributes to the burden, again, is that it typically is recurrent. So within 12 months of an episode, a third of people will have a recurrence. The first issue that I was going to talk about was differential diagnosis, and this is a slide taken from a paper by Rick Dio, and it's deliberately complicated because these are all the potential diseases that could cause low back pain. And when you first look at it, it's sort of overwhelming, but then the trick here is that, in fact, most of the diseases that are listed are incredibly rare. So if I sort of take the laser pointer, most of the conditions that you see come into this category of mechanical low back pain, and Rick suggested that it was probably around 97%. And all these other conditions that we sometimes worry about, or we should worry about, they're actually quite rare. So these sort of inflammatory, nasty diseases, serious medical pathologies probably account for 1%, and visceral disease masquerading as low back pain accounts for about 2%. So if we're going to put that on a pie chart, the majority of people will fit into this category which has got the question mark. So people turning up in primary care with low back pain. they usually have the diagnosis non-specific low back pain, which simply means we can't specify the anatomical structure and the pathology that's responsible for their back pain. And in terms of the other categories we would put people in, there's sciatica, canal stenosis, fracture, serious disease, and visceral pathology. So that's the breakup that was suggested by Rick Dio probably almost 2 decades ago. In terms of screening for people with medically serious disease, red flags are quite commonly used. And if you look at all guidelines, they all suggest to use red flags. The thing that's interesting is they all suggest a slightly different set of red flags. And so I became quite interested in chasing down the research about the red flags in terms of diagnostic accuracy. If you look at this guideline from the West Australian Government about imaging, they suggest if you have even a single red flag present, you should send people off for imaging. And so the presence of a red flag in this particular guideline is the starting point for the imaging for people with back pain. And that's important because we spend about $220 million each year on imaging for low back pain. And there is some thought that not all of that is actually necessary, not all of that is high-value healthcare. We looked at the issue of how common serious disease was in primary care, and we conducted a study in Sydney, and we looked at people presenting to chiropractors, physiotherapists, and GPs, and this is the study that we published a little while ago. It was led by Nick Henschke, who was one of my PhD students at the time. What we did was we enrolled about 1,200 consecutive cases of people with acute low back pain. It had to be the first consultation because we needed there to be diagnostic uncertainty. And we got the clinician to fill in these red flag screening questionnaires, which were the red flags. They also had to come up with a diagnosis day one. And we followed them for 12 months to come up with a definitive diagnosis, which was confirmed by the study rheumatologist. And what we found was actually quite good news. Serious pathology was rare in that group of people. So with about 1,200 people, there was only 11 confirmed cases of serious disease, 8 fractures, 1 case of cortical syndrome, 2 cases of inflammatory arthritis. So serious disease is quite rare. But the important point is that the red flags that are suggested to be markers of serious disease are in fact very common. So 80% of people in primary care with back pain have at least 1 red flag positive. The median score is 2. So 50% of people have got 2 red flags positive. And some of the red flags have very high false positive rates. And because serious disease was very uncommon, virtually all the positives for red flags are false positives. And you can see there, they're very high rates. For example, this one, okay. So the point I was making was that red flag for inflammatory joint disease was positive in more than 1/3 of people, and it's highly unlikely those people had inflammatory joint disease, not 1/3 of those people. If we're looking at what's the consequence of all that, well, that pie chart that I showed you originally, probably even smaller for those specific diseases, and the non-specific low back pain category is much larger. If you go and have a look at the West Australian Imaging Guideline, the consequence is that if you send everybody off who have at least 1 red flag positive, you're going to be sending off 80% of people for imaging, which is obviously not the right thing to do. So the advice that you should send people off for imaging if they've got 1 red flag positive needs to be reconsidered. We also conducted a Cochrane review looking at red flags to screen for malignancy and fracture. So there were 2 separate Cochrane reviews which we merged and published as 1 paper in the BMJ. And if I just wanted to go through those as the next source of information about red flags. So what we did was we looked through all the studies that had looked at red flags, and we found a whole range of studies. There were 29 single red flags that were studied, 20 for cancer, 29 for fracture, and 5 studies looked at combinations of red flags. In terms of the way I'm going to present the data on diagnostic accuracy, we're doing it with a nomogram here. So this is the red flag that's used to predict fracture, so prolonged corticosteroid use. And we've got a pretest probability or the prevalence. It's got a likelihood ratio. And then, let me make the dot work again. So we've got a positive likelihood ratio and a negative likelihood ratio. And if you follow them through here, this is the pretest probability. If the test is positive, that's the red line, you end up with a 33% chance that the person's got a fracture. And if it's negative, it drops you down to 1%. So in terms of red flags, they're usually informative when they're positive. They're not very informative when they're negative because the pretest probability is quite low. To then progress to the next slide, hopefully. These are the red flags that we found for detecting fracture. What we've got is the probability of fracture on the horizontal axis going from 0 to 100%. The vertical line is the pretest probability. The green dot is if the red flag is absent. The red dot is the probability if the red flag is present. and the shading is the 95% confidence interval. And what you can see here are the red flags that have been suggested as useful for screening for fracture, so being old and female, corticosteroid use, trauma. And what you can see is that most of the red flags aren't particularly useful when they're positive. It doesn't move you sufficiently along here to go across some sort of decision threshold. The one exception would be prolonged corticosteroid use. And so some of these red flags are not particularly useful in screening for fracture. One thing that we did find was that the combination of red flags was informative in terms of screening for people with fracture. So this is a rule that we developed based upon these 4 features, being female, being older, significant trauma, and prolonged corticosteroid. If you had one of these present, it moved you a little bit. If you had 2 present, it moved the post-test probability up to about this point. By the time you had 3 positive, it moved it up to this point so that the probability of fracture was really quite high, and you need to send people off for imaging in that particular case. So the good take-home point from this is that single red flags are probably not useful, but the combinations of them are a much better starting point to think about imaging for patients with back pain. We also looked at screening for cancer, and what we found was there's a whole range of red flags that have been suggested, such as being old, losing weight, not improving over 1 month. All these features here don't increase the probability of cancer. The only thing that increases the probability of cancer is a previous history of cancer. So in terms of red flags that are useful to screen for cancer, the only one that we found that was useful was a previous history of cancer. These other ones here seem quite blunt tools to screen for cancer in people presenting with low back pain. So this would be the take-home message, I guess, in terms of that great set of red flags that have been endorsed in guidelines. There are quite a lot of them. What are the ones that are useful? Well, in terms of screening for fracture, prolonged use of corticosteroids, that combination of red flags, which was made up of 3 red flags positive from female gender, greater than 70 years of age, trauma and corticosteroids, and also the presence of contusion or abrasion in an accident emergency department. And to screen for cancer, a previous history of cancer at the moment seems to be the only test that's useful for that. What I wanted to present to you in the next series of slides is, I guess, these 2 studies that we've done looking at paracetamol for low back pain, which was a clinical trial called PACE, and also a recent systematic review that we've published in the BMJ, which looked at the value of paracetamol for back pain and also for osteoarthritis. And the reason I wanted to show these to you tonight is because both of these studies have got incredible media interest because of the unexpected results. So the first one we're going to go through is the PACE study. To give you some indication of the interest in the study, this was featured on the front page of the London Times at the same time as the MH17 disaster where the Dutch plane was shot down. So that's a picture of the royal family. So the world's interest was in that tragedy, but they still found time to devote the front page to this particular study about PACE. And so we were completely shocked with the interest in the study. Why we're interested in paracetamol was because it's a really common over-the-counter medication suggested by GPs to their patients. So in terms of data, about a quarter of people who consult with arthritis are suggested have been recommended over-the-counter use of paracetamol, and about 20% in terms of GP consultations for back pain. Most of the guidelines around the world suggest that paracetamol should be the starting point as an analgesic for back pain and also for osteoarthritis because it's a simple, safe medicine that's low cost. And in PACE, we wanted to look at a couple of issues. We wanted to find out whether taking paracetamol results in more rapid recovery for people with acute low back pain. And we compared paracetamol to placebo, but we also looked at different dosing approaches. So we compared taking it as required to taking it regularly. So in this particular study, there were 3 arms. There was a placebo paracetamol arm, a regular paracetamol arm, and an as required or PRN paracetamol arm. We conducted the study in Sydney, mainly recruited from general practice, but got a few from pharmacies. And then we just screened consecutive patients. The inclusion criteria were fairly straightforward. They had to have acute low back pain and they had to be causing moderate intensity pain. We wanted them to have sufficient pain that we could sort of measure some improvement over time. We excluded people with serious pathology, as you'd expect. We excluded people with surgery. We also excluded people who are pregnant or planning pregnancy because of concern from GSK, who one of the sponsors of the trial. From my understanding, paracetamol is believed to be quite a safe medicine to take in pregnancy, but the company was very vigilant about that and wouldn't allow us to recruit those people. So in terms of what we did, this was a double dummy placebo-controlled trial, and so people had 2 lots of tablets. So the people in the regular group, their regular tablets were the real active paracetamol, and in their as-required tablets that they took, they were placebo. The next group, who received as-required paracetamol, when they took their tablets regularly, they were placebo tablets, or sugar pills, I guess, and the active tablets were in the as-required box. And the people in the placebo group, although they had 2 lots of boxes with 2 lots of medicines, for those people, there were placebo tablets in their regular box of medicines and also their as-required box of medicines. And the regular dose was to take 2 tablets 3 times a day because we used the extended release formula. And the as-required medicines, they could take 2 tablets up to 4 times a day whenever they thought it was required. And we batched the medicines so they were indistinguishable. So it was double dummy. Neither the patient, the assessor, or their clinician could tell what sort of medicine they were taking. Our primary measure was time to recovery, and so we measured recovery on this pain scale, and so it was from 0 to 10, and we decided that the primary measure of recovery would be the first of 7 continuous days of 0 or 1 pain. I mean, it was basically upon the view that we thought that it would be important for patients to not just recover, but to have sustained recovery for at least 1 week. And our secondary outcome was the first day of 0 or 10 pain. We also collected a whole range of secondary outcomes, the sort of usual candidates: pain, disability, and function. To give you an idea of what happened in the trial, we enrolled 1,652, roughly a third in each arm of the study. What you can see if you run through the flow chart is that we excluded a few people for diseases that became apparent later. They were post-randomization exclusion, but we followed up virtually all of the cohort. In terms of their presentation, they had quite severe pain. On average, it was about 6.3 out of 10, and their back pain was quite fresh. It was about 9.9 days between their back pain coming on and when they entered the PACE trial. These are the results for the study, and these are the results that were quite surprising to us and were really the reason that the study got such great publicity. These are survival curves for the 3 groups. This is for regular paracetamol, placebo paracetamol, and as-needed paracetamol. This is the cumulative frequency of recovery, and this is time on the horizontal axis. And what you can see with these 3 survival curves is there's no difference between them. So the median days to recovery in the 3 groups is approximately 17 days. So people recovered very quickly, but there's absolutely no difference between taking regular paracetamol, as-needed paracetamol, or placebo tablets. And that's the result that really shocked us and surprised us. We also looked at all the secondary outcomes, and I can skip through these really quickly because for every single secondary outcome we found no evidence of any difference between those three arms of the study. These are the results for pain outcomes, and so you can see in the 3 groups what their pain scores were at baseline, week 1, 2, 4, and 12. And what you can see is that within a group over time, their pain rapidly reduced. But if you compare across the different columns, there's absolutely no difference in the pain scores. So looking at 3.7, 3.8, 3.6 at week 1, and then going all the way up to week 12, there's absolutely no difference between those 3 groups. And we found that same pattern across all of the secondary outcomes. And so the surprising result of PACE was that regular or as-needed dosing with paracetamol does not affect time to recovery or any of those other secondary outcomes, and it called into question the universal endorsement of paracetamol for acute low back pain. So in terms of what was the message from the PACE study, I guess we had to think long and hard about this because it actually was a really unexpected finding. We were expecting to see that there would be a difference between the 2 dosing regimens, and we thought that if you took paracetamol regularly, you get a much better result than the as-needed, but we never expected that both would be completely ineffective. And so thinking about this particular issue, it seems like we need to stop giving people paracetamol for acute low back pain because it doesn't work. Maybe the mainstay of therapy for these people with acute low back pain should be giving them good advice, reassuring of the favourable prognosis and encouraging them to return to normal activity rather than relying upon medications. If you do want to give people medications, this particular trial would suggest that paracetamol is not going to be useful, and if you need to give people a pain medicine, you're going to have to think of some other sort of pain medicine. So there's been a lot of ramifications from that study, and we're still thinking through what it means for clinical practice guidelines. Shortly after we published that, there was this literature review that came out which looked at, I guess, the side effects of paracetamol. And although paracetamol has this record of being a very safe medicine, this particular review, even though it was of observational studies, suggested that you actually, if you take paracetamol over a sufficiently long period of time, it does increase your risk of mortality, cardiovascular, poor outcomes, GI and renal adverse events as well. So that sort of got us thinking about the issue of the balance of benefits and harms of paracetamol. And so what we wanted to do was to sort of look at that in a systematic review, and so this led us to the study that was conducted by Gustavo Machado, who's a Brazilian PhD student of mine. And the background to this was that initially in the UK, the guidelines about osteoarthritis and whether or not they would endorse paracetamol, the evidence committee went away and looked at the clinical trials and recommended that it be removed from the guideline. And the other group that were involved, the consumers and the clinicians, said, no, we want it put back in again. So at the time, there was this tension between whether paracetamol should be or should not be in the UK guidelines. And they suggested that we needed to have an updated systematic review of all the evidence. And that was sort of one of the reasons why we did this review that was published in BMJ. And so this is the paper that was published at the beginning of this year. It's had incredible publicity. It's in the top 1% of papers in the BMJ in terms of downloads and citations and those sorts of things. So it's been incredibly popular and generated a lot of interest. We've had lots of letters to the editor. There was also an editorial about this as well. So what we wanted to do was to look at the efficacy of paracetamol, summarising it for back pain, so not just the PACE trial, but all trials we could find. And we also wanted to look at, well, what's the body of evidence for paracetamol for osteoarthritis, looking at all trials that we could find. We also wanted to look at the safety of the drug measured within randomised controlled trials, because that other review that I pointed to was based upon observational studies, and some of the downfalls of observational studies is that you can get confounding there that can upset the interpretation of the results. And within a randomised controlled trial, you're going to get more robust information about adverse events. So what did we do? We included randomised controlled trials. They had to compare paracetamol to placebo. We were interested in when they were used for spinal pain, so that could be low back or neck pain, osteoarthritis of the knee or hip. We excluded trials where people had serious spinal pathology or rheumatoid arthritis. We converted all the scores to a 0 to 100 scale to make it easier to interpret. We looked at immediate effects of paracetamol. We called immediate between 0 and 2 weeks, and short-term effects were above 2 weeks up to 3 months. We compared the results differently for spinal pain and osteoarthritis, and if you're interested in systematic reviews, this is the sort of mathematical or statistical approach that we used. Basically, we sort of averaged all the results from the individual trials, and you got more weight if the trial was bigger. We found 3 trials that had evaluated paracetamol versus placebo for low back pain. We didn't find any for neck pain, which is quite interesting. We found 10 trials that looked at the use of paracetamol for osteoarthritis of the knee or of the hip. And it represents about 5,000 patients. And so at one level, that's a lot of patients. But if you think about the universal endorsement of this treatment and how widely it's used, that's actually not that many patients. So what did we find? Well, this is a forest plot which is giving you the results for the low back pain trials. And so there's one trial by Wetzel. There's the trial, or the PACE trial. The main author was Williams. And we've put because it's a 3-arm trial, it can go into the systematic review twice. One arm is for time contingent paracetamol, and the other arm is for PRN. And we've got the results in the immediate term for pain and for disability. 0 is where there's no difference between paracetamol and placebo. These are the effects for individual studies and the 95% confidence intervals, and the diamond is the pooled estimate. So if we just look at the top one, this is the pooled estimate, the effect of paracetamol versus placebo. on a scale from 0 to 100. The point estimate is 1.4, but it crosses 0, so there's no statistically significant effect of paracetamol on spinal pain when you look at all those studies, and the same with for disability. When we have a look at the short-term results, what you can see here is that we get much the same result. That in terms of pain and disability, there's no statistically significant effect of paracetamol versus placebo, which is what you'd expect because we're basically summarising the PACE trial again. The interesting thing was that when we looked at osteoarthritis, we found something very similar. So these are the individual trials for osteoarthritis comparing paracetamol to placebo. Again, we've got the individual studies. This is the pooled estimate at the bottom. In this case, for pain in the immediate term, there is a statistically significant effect, but I have to point to you how small the effect is. So this is 3 units on a 0 to 100 scale. Mostly when patients talk about their pain, they might say it's a 6 or a 7 out of 10. People tend to think that the minimally clinically important difference on a pain scale from 0 to 100 is more like 10 units. And so this difference is measurable when you summarise large numbers of patients in clinical trials. It would be imperceptible to an individual patient. So it's statistically significant but not clinically important. In terms of disability, the effect is again very small. In this case, it would be imperceptible. It's also statistically not significant. So this was the really surprising result. When you summarised all the evidence for osteoarthritis, in the immediate term, it seemed like this medicine was not particularly useful. And in the short term, we got much the same result as well. So these are the results for pain in the short term. This is the pooled result here. The result is about 3 units difference on the 0 to 100 scale. So again, a trivially small difference. It was just statistically significant. But I think most people would not be able to appreciate this very small difference in their pain. And so this was a really surprising result to us because people had suggested that paracetamol was a useful treatment for osteoarthritis, but our results would question the utility of this medicine for osteoarthritis. We also looked at the issue of adverse events, and so in terms of any adverse event, overall there doesn't seem to be a difference between paracetamol and placebo. So this is the risk ratio, which is about 1, so the risk is no greater in placebo versus paracetamol, looking across all of these trials. There was one category of risk which was different, which I need to spend a little time talking about. And this was in terms of abnormal liver function tests. And so this were defined by abnormalities in hepatic enzyme activity, which was greater than that reference range. And when you defined that as an adverse event, what we found was that the risk of having one of those adverse events or the abnormal liver test was about 4 times higher if you took paracetamol compared to placebo. And so that tends to suggest that there may be some harm there. But I need to point out to you that this was, I guess, a liver function test, it's a blood test. These people, when you actually ask them about their symptoms and stuff, they weren't actually reporting symptoms. And so the clinical significance of this abnormal liver test is unclear. So where do we get to next? Okay, so what's the conclusion? Well, based upon that systematic review, we would say that paracetamol is ineffective in reducing pain and disability for low back pain, and that seemed to be pretty clear. In terms of what it does for osteoarthritis, the effect is statistically significant, but when you looked at the size, it's tiny. It's about 3 units on a 0 to 100 pain scale, and we would argue that that's probably not meaningful for most patients because, as I said before, about 10, in this case we've written down 9, that seems to be the magnitude you need to see for people to be able to perceive that as a difference in their pain. And there's also this other finding we found, which was that you do seem to have a higher risk of an abnormal liver function test. It increases by a factor of nearly 4. But I need to say, just to be clear, the clinical significance of that is not known at the moment because those other adverse events weren't different between the different groups taking either paracetamol or placebo. Well, what happened after we published that? Well, it was published with an editorial, and they were suggesting that we need to think about, well, what do we do for people with back pain and osteoarthritis in an era when we won't be prescribing paracetamol. So the two people who were providing the editorial, one of them was a GP, one was a rheumatologist, they both came to the conclusion that you should stop using paracetamol and instead use physical treatments for people with osteoarthritis and paracetamol. So in terms of people with osteoarthritis, in terms of what you would do for people with osteoarthritis, a greater emphasis on lifestyle interventions such as weight control, physical activity and exercise, and they were suggesting much the same approach for back pain. Because both of them are clinicians, they said, well, they do have a bit of a problem with that because although you can get paracetamol fairly readily, in many healthcare settings, it's quite hard to access some of these other health services for back pain and osteoarthritis, which are known to be effective but are not covered by the MBS. So, for example, it's very difficult in Australia to get a properly supervised, progressed exercise program for people with osteoarthritis because it's not covered under MBS. You can get a small number of sessions under the chronic care program, but I think it's limited to 6 and has to be shared across all diseases and across all allied health providers. And so squeezing in a proper exercise program for osteoarthritis is quite difficult. And so we've got this challenge in that we know something seems to work for osteoarthritis, but it's not reimbursed or covered under the MBS system. And paradoxically, there's some other things which are covered by the MBS which we know don't work for osteoarthritis. So I think at the moment, this is an interesting idea. How do we align health policy and funding of healthcare services so it aligns with the newer evidence that's emerging? And certainly Christian Mellon and the rheumatologist Elaine Hay that was commenting said we really need to think about big picture stuff about health policy and funding in terms of what we're doing for both back pain and osteoarthritis. And I guess that was the conclusion from that systematic review in the PACE study. We really need to reconsider the endorsement of paracetamol in clinical practice guidelines for back pain and for osteoarthritis. And at the moment, I know that's happening. People are thinking, what should we do? Should we take it out completely? Should we say it may not work? Should we just ignore the evidence from these studies? I think most people have moved to the position that you can't ignore the evidence. You at least have to suggest that maybe it's not going to work, but maybe give it a try. Other people are saying don't even bother endorsing it in guidelines. So that's where we are at this current point in time. I think we've got time to do the last thing. Yes, we do. We're on track. So the last thing I wanted to cover was this particular study that we did, which was looking at the issue of what triggers an episode of acute low back pain. And we've done a series of studies which have been published based upon this one data set. And so this particular study design is interesting one. It's a case crossover study, and so this looks at exposure to factors which would trigger some sort of disease that happened just before the incident. So it's really good for looking at sudden onset conditions, and it's been used to examine risk factors for a whole range of things, so risk factors for asthma, risk factors for myocardial infarction. And so they look at what happens just before the disease and contrast that to exposure and what happens in the control period distant from that rapid onset. And the value of this approach is the patient's their own control, and so you get much better controlling of confounding. And so we've used this particular design to look at exposure to different physical risk factors for an episode of acute low back pain. And we've also mapped our data to weather data from the Bureau of Meteorology to evaluate the idea that weather or changes in the weather can increase your risk of acute low back pain. This particular study I'm going to present to you today looks at the standard triggers, and I'll explain that shortly. This study was done by another one of my Brazilian PhD students. I seem to have lots of Brazilian PhD students at the moment. They're very bright and do a great job. So this one was from Daniel Steffens, who's finished, and he's working at Neura as he's working there as a postdoc at the moment. So in terms of why we wanted to do this, I think there's lots of information about long-term exposure to risk factors, so things such as smoking, physical fitness, social class, body build and age, and whether those things increase your risk of low back pain. And that's all really interesting, but when you talk to patients, they often attribute their back pain to things which happened just before the back pain came on. And if you're thinking about it, things such as lifting awkwardly, being distracted when you're doing a task, slipping and tripping, they're often mentioned by patients, and the best way to look at these and to discover whether these actually do increase your risk of back pain is this case control design. And the case control study is really good at looking at this particular issue that, was your pain or was any disease triggered by something unusual that happened just before the onset of the disease. And we understand usualness by comparing exposure in the period just before to a control period distant from the episode of this condition. So to illustrate it, if this was an episode of low back pain coming on, we'll call that the adverse event. We have a case window that extends backwards a period of time, so maybe a couple of hours. We look at exposure in the case window, and we compare exposure to a control window, which is distant, when there was no adverse event or no back pain. And so the person is their own control in this design. So we could use it to look at exposure to things such as lifting a heavy object in the case window just before the person had their back pain, and look at it 24 hours earlier. And if we wanted to, I think we've got this, oh, we don't have that slide. You can also have other control windows. You can have a control window 2 days before, 3 days before, just to get a better idea of usualness. In this particular study, we were interested in looking at triggers that have been suggested in a manual handling guideline from the Australian government as being risky. So they suggested that manual tasks involving heavy loads, awkward postures, all these sorts of things here, increase your risk of getting back pain. There was also some suggestion that physical activity might be harmful, slipping, tripping, consumption of alcohol, sexual activity, being distracted and fatigued or tired. And so what we did, we asked people about exposure to all these triggers in the period just before their back pain and going back for a full 4-day period. And we didn't tell them about when the case and the control windows were to blind them to that aspect of the study. We just interviewed them across the whole 4-day period about what they were doing. We got 1,000, roughly, just short of 1,000 patients from primary care, new episode of low back pain. They had to have moderate pain intensity, had to come on suddenly. We interviewed them within a week of referral, and we had trained staff and we piloted a script. And we used this form of analysis called conditional logistic regression. What we found, which was really quite interesting, was that in terms of when the back pain came on over a 24-hour period of time, so this is 24 hours, this is just after midnight, this is just before midnight, this is about the time that some people wake up, what you can see is that you get this strong diurnal pattern in terms of back pain onset, which we hadn't thought about previously. So back pain's more commonly coming on first thing in the morning and less commonly coming on later in the evening. So we have different theories about what that might be, and so we're talking to biomechanists, people studying discs and plumpness and hydration of the disc to try and work out, well, does this fit in with what we know about the biomechanics and the physical characteristics of the disc, and maybe that explains what's going on here. But to our knowledge, this is sort of the first time people have talked about that strong diurnal pattern. Just to give you an idea of the study, this is the exposure frequency in the case window, which is just before the back pain. This is the control exposure. And what you can see if you know nothing about statistics is that you had, for example, for this exposure to heavy loads, they were much more likely to be exposed in the case period than in the control period, which is a suggestion that these things are harmful because the exposure is quite different. But, for example, exposure to sexual activity, the frequencies are much the same in the case period as in the control period. And when I convert those exposures to odds ratios, and so this is a measure of how risky each one of these triggers are, they range from 1, which means no risk, less than 1 means they're protective, above 1 means they're harmful. What you can see is that these triggers that we measured, virtually all of them were quite harmful. They increased your risk of low back pain. Some of them, I guess you would have thought about, but some of them probably not. So things like loads that are difficult to grasp or hold, the odds ratio is really quite high for that. The one which I think is really quite interesting is that if you're distracted during an activity or task, the odds ratio is really huge with that. It goes up to 25. The good news is that we found that these two risk factors were not significant, which was fortuitous for us, because if we'd found that they were harmful, it would have left us with a really hard public health message to sell, probably in Australia at least. We wanted to look at the issue about whether if you had exposure to more than one trigger, whether that increased your risks, and what we found was it was actually true. So these are individual odds ratios for those 3 triggers. If you combine them together, you get an odds ratio that's bigger than those individually. So exposure to more than one trigger is more harmful or more dangerous than exposure to just one trigger. We also wanted to see if people who were habitually active, whether the physical activity would protect them from those risks, and we really didn't find much evidence of that. So the idea that if you're more physically active and fitter, you can go off and do what you want and you'll be safe. We didn't find evidence that that's the case. The last thing, which was promoted by my PhD student who's young and probably at my expense because I'm old, was to look at 2 triggers and to see if the risk was moderated by age. And so he wanted to look at the idea whether heavy loads, whether the risk associated with that is moderated by age. And he also decided to throw in sexual activity. What we found was that, interestingly, heavy loads, the risk associated with that was increased, was moderated by age, but counterintuitively, heavy loads were less harmful the older you are. And we thought maybe that's because people become wiser as they get older. Unfortunately, the risk associated with exposure to sexual activity becomes statistically significant for older people, and I'll explain that in the next slide. So in terms of manual tasks, these are the odds ratios if you're younger. So the odds ratio is higher if you're in your 20s compared to if you're in your 60s. In terms of sexual activity, the odds ratio here, it's just statistically significant and it seems to be protective, whereas if you're in your 60s, exposure to sexual activity, there's a trend, it's not statistically significant, it seems like it's actually harmful. So the PhD student was quite happy with that result. So what would I say was the discussion from that trigger study? Well, it's the first case crossover study in low back pain, and I think it's quite an interesting approach because it's thrown up quite a lot of good information that we can use for prevention activities. It showed that even short-term exposure dramatically increases your risk of low back pain. It showed there was this strong diurnal pattern of low back pain that people hadn't talked about really before. There's a little bit of evidence that age moderates the effects. In terms of the strengths of the study, it was a large representative sample. We used this design that controls for unmatched confounders because genetic and lifestyle factors are thought to be important in the genesis of low back pain. And so if you use people matched to other people, you've always got a problem unless you've got twins. But the best way to match is to have the person matched to themselves. And so the case crossover design is perfect for that because each person is their own control. And what we found was that there were these factors which had high odds ratios and they're quite modifiable. So in terms of designing prevention strategies, I think we've got a lot of opportunities here. There are a few little limitations. There is a potential for recall bias that you need to understand as well. So what we would like to do in the future, we'd like to move on from this and translate this information into prevention strategies. We'd also like to look at other triggers, and I'm quite interested in trying to track down what's behind that diurnal pattern of low back pain onset. Why are you more likely to get back pain in the mornings than you are noon and in the afternoon? So where did we get to? Well, hopefully I've finished almost on time. What I'd like to do would be to acknowledge a few people. The work that I've presented to you is obviously not just my own work, so I need to acknowledge my colleagues that I work with, particularly the PhD students who drive these projects. In terms of how does research get done, we really need to acknowledge that most of the work that gets done in research institutions is probably driven to a large extent by PhD students, and often they're not acknowledged enough, and so I really want to thank them. I want to thank my colleagues who are the co-authors on the studies. I need to thank the National Health and Medical Research Council who fund my fellowship, and before the National Health and Medical Research Council funded me, I was funded by the Australian Research Council. So those two groups have paid my salary for the last 10 years. Without them, I wouldn't have a job, I wouldn't be here. And I think we've got time, well, we're finishing on time, we've got time for questions now.
Okay. Thanks very much, Chris, for really fascinating overview of your research that you've done in recent times, and it certainly does sort of raise a lot of questions in relation to current practice and so on. A couple of questions have come in, and I encourage people to ask further questions now before we finish up for the evening. The first question that came in, Chris, was in relation to the issue about imaging, and you've sort of in your discussion about the red flags, and you were sort of saying one question is in relation to often patients' expectations that if a GP doesn't send the patient for an X-ray, that the patient doesn't think that they've actually, done quite enough. So do you know of any studies or evidence in relation to the influence of the patient's expectations on the actual sort of conduct of imaging or not?
Yeah, well, that's a really good point because, I mean, it's really easy to point the finger at the GP or the physio or someone, but it's actually complex. what's been shown is that patients expect imaging, and they seem to think that if you don't image them, you won't have a basis, you won't have a logical basis for therapy, and if the doctor doesn't do that, then the doctor's not doing their job correctly. And that's been discovered in qualitative research in a number of settings. There is data from Tammy Hoffman where they've actually surveyed Australians about that particular issue. So Australians hold that view that if you've got back pain, the GP should image them. The reason for that's complex. I think the problem is that most people misunderstand low back pain. And I think it's a little bit like the beliefs about needing antibiotics for the common cold. We had to have public health messages about that to try and explain that. We have to do the same thing for low back pain to make the job easier for GPs to say, no, you don't need this, because I think it's a really tough ask. You know, people have got strong beliefs. For the GP to sort of have to spend all the time to correct those beliefs is pretty tough. So I think we need to think about public health messages about educating people about back pain, because it's so common. It's a public health problem, strong misconceptions. We need to clarify, you know, issues about imaging, but also about bed rest, about going back to physical activity, you know, use of medicines. You know, there's probably, you know, 5 or 6 key things that if we could get those across to consumers, it would make their health better, but make it much easier for GPs and physios and chiropractors to manage health and provide better health services for these patients.
Okay, another point that was raised in relation to your study with the use of paracetamol versus placebo and so on, a query with regards to paracetamol being for pain relief, not necessarily resolution of the back pain problem. Is that correct?
Well, we measured pain relief as well. So we measured time to recovery, we measured pain intensity, we measured intensity of disability, we measured quality of life. We measured about 10 different things, and there was absolutely no difference on any of those outcomes. We also, I didn't present the data here, we got people to fill in a pain diary every day until they'd recovered. So we had really precise measures of people's pain intensity every day, and there was no difference between those 3 groups. So it doesn't seem to have a pain relieving effect. Not measuring pain every day.
In relation to your talking about the red flags, are there any sort of red flag screening questionnaires that you would recommend that people use?
Yeah, I think the best summary is in the American Pain Society guideline. That's quite good, and also the Intermountain Healthcare guideline. Unfortunately, over time, guideline committees have tried to do too good a job and put lots of red flags in, but the guideline by the American Pain Society, which was put together by Roger Chow, has probably been more restrained and gives you a much smaller subset of the useful red flags. So I'd suggest that one.
Another question in relation to whether movement and stretching is not actually good for back pain.
Movement is good for all forms of back pain. So if we start from the idea of prevention, there are some studies from Europe showing that you can prevent recurrences of back pain using an exercise program. The studies suggest you could halve the risk of recurrence. In terms of treatment of acute low back pain, we know that promoting physical activity and avoiding bed rest is useful, so that part of movement is useful. So people with subacute and chronic low back pain, a supervised exercise program is useful. So I think it's really the balance between rest and movement that's critical, and for acute, it could just be the physio or GP guiding the patient about returning to activity. Once you've got chronic low back pain, it seems to be more like a supervised, structured exercise program that's necessary. And so you need to have that flexibility across that spectrum.
Also, would you consider the incorporation of a measure of stress or anxiety as a possible precursor to acute back pain onset? Yeah,
I mean, that's known to be a risk factor. So stress at home and stress in the workplace increase your chances of getting low back pain. And so if people ask me, what can I do to prevent back pain? And so the message would be to live a healthy lifestyle the same as you do for heart disease and also cardiovascular, those sorts of things, using your back sensibly. But the thing that it's hard to do, and we probably need to think more carefully about, is reducing stress in your life. If you can do that, it reduces your chances of getting back pain.
Okay, we have a comment and a question here about that most clinicians would support the idea that patients with OA or low back pain don't approve a clinically meaningful amount when just taking paracetamol, and that's often what's seen clinically quite commonly. Might paracetamol have a more important role in enabling patients to engage in physical activity by creating a therapeutic window, and would this be a better clinical guideline recommendation?
Well, we sort of looked at that because we had measures of disability using the Roller Morris. We also had the patient-specific functional scale, which is where we get people to nominate function activities they'd like to return to that are important for them. And we also had the SF36. And across all those measures of physical function, there were no improvements. So the theory that paracetamol creates this window to get you more physically able compared to not having paracetamol, we didn't have any evidence that that was the case.
With regards to the diurnal pattern of low back pain, were you reporting that the episode of pain was triggered in the morning, or that people commonly suffer from low back pain in the morning?
That was when the starting point was. So we asked people to tell us when it came on, on a 24-hour clock, and there was much higher frequency at around 7 o'clock from my memory, then sort of peaked around noon and then dropped off. And so when we talk to biomechanists, there's some theories about disc hydration, and there's a little bit of evidence about that, so that the disc is more susceptible when it's very hydrated and plump, and as the day progresses, that's less of that. And so biomechanists think maybe that's, if you're thinking that some back pain is due to disc problems or disc injury, they think there's a biological reason why we saw that diurnal pattern related to disc hydration.
Okay, and also, should the paracetamol study have included a no tablets arm, as taking even a placebo may have aided in recovery?
Excellent question. We're just about to do, we're trying to get money for that study now. So one of my colleagues is quite interested in that question, and we're trying to replicate and extend PACE. And so what we're thinking of doing, exactly what this question is to have an arm that gets nothing. And so that would give us, the paracetamol, placebo, and nothing, and see whether that would help tease out that particular issue. We're also going to include an NSAID arm as well. And so often when you do a study, it sort of leads you to other studies. But I'm glad that that person raised that question, because we think it's an interesting one as well. Because maybe there is something about giving people a placebo, even though it's inert, and that would put us in a really difficult situation. We found out there's a difference between giving people a pretend paracetamol tablet and not. Do you actually start giving people pretend paracetamol problems? So as a scientist, it's really interesting. In terms of what clinicians would do, I guess that's more complex.
I suppose we've got another question coming up, and we've only got a few minutes to go. It's just someone's commenting that it would be interesting to know whether the low back pain arose in the morning only on weekends, weekdays as compared to weekends.
It's a good point. We've got a lot of data because we had 1,000 people, but I have to write that one down because we didn't think about that one. That's a great idea. So no, we haven't looked across weekends versus weekdays, but with the amount of data we've got, with 1,000 people, we could do that. I'll take that idea.
That's good. Very good interaction. Just one last point, Chris. Any sort of advice for sort of clinicians and practitioners in the fact that the evidence is saying one thing, the health policy and guidelines are taking a bit of time to catch up. Any last parting comments on your part?
Yeah, well, I think rather than being negative about taking paracetamol out, I think this is an opportunity for people to add value to these other parts of care which we know are useful for back pain, but also we know aren't provided as routinely as they should be. So in terms of, my understanding of the advice for acute low back pain is you need to talk to your patients and explain things. You need to get them moving again. You need to teach them about self-management. The surveys of practice would suggest that for both osteoarthritis and back pain, when people turn up to primary care, they often miss those essential things. So rather than saying, let's worry about whether paracetamol works or not, my message would be, let's work out whether we can give them these other things which we think are important, and what's the best way within my clinic that I can structure the practice to give them to patients. Because patients do value those sorts of things, and at the moment they're missing out on them. So I think that's the value add that I'd suggest from the studies we've done. You know, less importance about paracetamol, more importance about talking to your patients, getting them moving, giving them strategies that they can do for themselves to help recover from their back pain.
Okay, on that note, I think we'll finish up. We're very close to 8 p.m. Eastern Standard Time. Chris, it's been a really fascinating presentation and just such comprehensive and interesting research. So on behalf of everyone, I would like to thank you very much for your presentation this evening. I'd like to thank all the participants who have attended the webinar this evening. I do ask that you take a moment to complete the exit survey. And on that note, I wish you all good night.